Dear colleagues, dear chair, I would like to present my complex exam presentation. So my PhD topic is cervical diseases and their connection with clinical and health factors. I am a resident doctor at the Department of Obstetrics and Gynecology, Semmelweis University. My supervisor is Jolt Meltzer. My vision is that primary HPV detection will be implemented in Hungary in the next 5 years in the above 30 years age group. And my mission is to change the Hungarian guidelines on cervical cancer screening. I have two projects to achieve my vision and mission. The first project is called trichomonas vaginalis. Infection is associated with increased risk of cervical carcinogenesis. To give some background, the lifetime prevalence of HPV is around 80%. So HPV is necessary but not sufficient for the development of cervical cancer. Of course, other factors are needed. And trichomonas vaginalis causes inflammation of the vagina and the cervix. And this persistent infection of the was caused by trichomonas vaginalis causes decrease of protective barriers and of the vagina and the cervix, and this inflammation might cause persistent HPV infection and in the progress of cervical carcinogenesis. And our aim was to assess the effect of trichomonas vaginalis on increased risk of cervical carcinogenesis. Our clinical question was that does trichomonas vaginalis increases the risk of cervical carcinogenesis. We had two PO frameworks. So basically, we looked for sexually active women who were TB infected, and we were curious about HPV infection, cytology, and histology. And in the second population, we were curious about HPV infected women. And once again, we were curious about TB infection, and we looked for cytology and histology. And the clinical application suggested that there is an association between cervical carcinogenesis and trichomonas vaginalis. So this was our systematic search. After that, we found 29 eligible articles. So I will now present some of the results. We did a subgroup analysis based on the detection method of trichomonasis, and we found that women who were trichomonas vaginalis infected had an increased odds for the detection of or the diagnosis of HPV co-infection. Now I will show results in connection with cervical abnormalities. First, this is forest plots based on, once again, the detection methods of trichomonas from the detection method. And women who were trichomonas vaginalis infection had an increased odds for the diagnosis of high-grade squamous intraepithelial lesion, which is the precancerous status of the cervix. This forest plot shows the association between trichomonas vaginalis and cervical cancer, and there is an increased risk in case of trichomonas detection. There is an increased risk for the detection of or the diagnosis of cervical cancer. And this forest plot shows that when women were HPV positive, both LCL, high-CL, and cervical cancer were associated with trichomonas vaginalis. So our strength, it was the first meta-analysis to investigate TB infection, HPV infection, and different cervical lesions. We had a huge sample size, nearly 500,000 of women. The data were analyzed. As globally representative articles from all around the world. The limitations were that these were mostly cross-sectional studies and not enough controls on confounding factors and high heterogeneity. The conclusion is that in case of detection of HPV infection and cervical intraepithelial neoplasia is increased in the trichomonas vaginalis infected population. And the implication for practice is that strongly suggested also screening and treating trichomonas vaginalis in case of HPV detection, and longitudinal studies are needed in this field. And we are very happy that we published this article in a Q1 journal in March. So the second topic is imiquimod. The title is imiquimod is effective on reducing cervical intraepithelial neoplasia. This is a systematic review. So to give you some background, guidelines recommend surgical therapy for cervical precancer or high-squamous intraepithelial lesion. But cervical conization increases the risk of cervical incompetence and premature birth. Topical imiquimod is an immune response modifier and currently approved for genital warts, basal cell cancer, and actinic keratosis. And in one study, imiquimod fastens HPV clearance by 60% compared to the control group. And our aim was to assess the efficacy of topical imiquimod on cervical intraepithelial neoplasia and also the safety. We had two clinical questions, basically because in many studies we didn't have a control group, so we used the co-investigator framework. But basically we investigated women who had cervical intraepithelial neoplasia, the usage of imiquimod, and we were interested about cervical intraepithelial neoplasia regression, HPV clearance, and adverse events as well. We did the second in the PICO framework, but of course in this we had a control group. We conducted our systematic research. We found 8 eligible articles, some of the results. Actually, this forest plot shows that imiquimod fastened cervical intraepithelial neoplasia regression around 60%. This is when we compared imiquimod to conization. This is the gold standard therapy of cervical precancer, and we found that imiquimod is inferior to conization. Women who were treated with conization had a 38% less decreased chance of treatment failure. This is forest plot of studies representing the HPV clearance after imiquimod use, and we found 50% HPV clearance rate. And when we had a control group, we found that imiquimod is not superior to the standard therapy or the control. I have to highlight it that the control was different in studies, so this is a limitation in this outcome. And these are of course, imiquimod is an immune modulator, so it causes inflammation, and therefore it has many side effects. It has systematic and local side effects. The local side effects were more common, like flu-like symptoms, myalgia, and also from the local side effects, vaginal pruritus was the most common. So some of the conclusions: imiquimod is effective on reducing cervical intraepithelial neoplasia and not dose dependently. Imiquimod fastens HPV clearance. The milder the lesion, the higher the HPV clearance. And side effects are indeed common, but mostly mild, and with NSAIDs it can be reduced. This was the first meta-analysis in the topic. We find positive results and also mild side effects. Some limitations to declare that we had a relatively low sample size. high heterogeneity and short follow-up times, and the findings are not always generalizable. So just in 1 minute, because I know I'm over time. So where could be this implemented? Women who have future pregnancy desire, they are the goal population. And after we do conization, and if the margins are positive, we could use imiquimod, because that could lower the need for reconization, which increases the risk of premature birth even more. And also considerable for low-grade sin, because psychological burden can be even greater than in high-grade sin due to the observational time. And further studies are needed in the field to understand better how imiquimod can reduce the burden of cervical dysplasia. So the manuscript is written, and we will, I think, we will send it to internal review in July. And thank you very much for your kind attention.
When HPV vaccination initiated in Hungary almost 20 years ago, the first protocol said we should give it to young girls around age 7 to 11. And they said if we follow this protocol, cervical cancer will disappear in around 20-25 years. It still exists. How do you explain that?
Well, I have several explanations. That actually, the first is that there is a huge generation gap. So now many women just didn't receive the HPV vaccine. So I think we have to wait another 20 years to come up with our results. And actually, Australia is a great pilot country, because the intake of vaccines in Australia is much greater than in Hungary, and they have very positive results in the population where they implemented HPV vaccination. And in that population, there is a big decline in warts, in the precancers, and cervical dysplasia. So I think, and also in Hungary, the HPV vaccination, the intake is not as high as we would like it or we would want.
What do you think about male vaccination?
It's absolutely should be. Women and men should be vaccinated against HPV.
Thank you.
We know that there are in some countries where the age of sexual activity is lower than in Hungary, for example. So where kids are involved in not I don't know how to say it. So at it's not by their choice. Yes, sexual abuse. Thank you. And do you aware of kind of information that do these girls develop cancer earlier, or because this is those societies where it's not so better, there is no good awareness of this kind of diseases, that it's hidden, or have you read something about this?
Interesting question. Well, definitely, if there is no adequate screening of HPV, then cervical cancer can develop more easily. Actually, the WHO recommends that every woman should have, or in other words, in case a woman have cervical screening just one time in her lifetime, that will itself decrease the risk of cervical cancer. So, of course, I think it's the question whether these countries have screening programs or not, because many don't have actually. So.
I think in Hungary there is a population which has other social rules than and in your practice, in your clinical practice, do you see any different incidence rate in cervical cancer in those social grades where they are not so familiar with the vaccination program and also with the screening, or the importance of the screening?
Yeah, exactly. I would turn around the question, and I would say that we should, with organized cervical screening, we should have a calling voice for women who are not in the cervical screening programs, because in most cases, not just in minorities, but in majority cases, we see cervical cancer and sometimes advanced cervical cancer in those women who were never screened actually, or very, very less. So it's once again is the question, how can we gather women into cervical screening programs, because this is the main question, and we have to achieve this as gynecologists too.
Is there an educational program for the primary school girls or for high school girls?
Well, it didn't have when I was a high school student, but
Neither do I. So.
yeah, so it should be, of course, and this would be nice. But this, and I think this could actually lower the incidence of cervical cancer. But this is up to the educational politics or policies. Yeah.
It's not the biological teacher who is the best for this. Thank you.
To be honest, this was the first time that I actually didn't feel like an outsider, because I worked with parasite ecology, and immediately as I saw trichomonas on your slides, I was like, oh wow, great. Now I understand what's going on. So thanks for that. Can we go back to that story?
Sure.
Just because, So what I didn't really understand here is, so this is the HPV infection rate with trichomonas, no infection. Okay. You were just very quick. Now I get what the slide is about.
Okay.
And you have 452,000 patients altogether pooled, and 77,300.
Almost half a million. Yes.
Okay. My main question is, why was it important to pool it based on the method, the detection method?
Yes, because of course we had to make some subgroups, and the sensitivity of the different methods are very different. For example, the lowest is cytology, and you can see that we found no significant results here, because actually the detection, the sensitivity is around 30%. PCR is almost like 92%, and also staining is an effective method. That was the reason, yes.
So if you're saying that for instance, stain is adequate because it's relatively, you get relatively high value, but with cytology it's not that great. So what I'm saying is that these methods, they depend on two things: A, how effective they are, and what's the prevalence of trichomonas in the population.
Yeah, exactly. That's the other main thing. What's called the heterogeneity. It does matter where you look at. If you look at it in Central Africa, it will be different if you look at it in Norwegia.
So the question is, because you have 452,000 patients in the study, could you not analyze the data based on region or some kind of an ecological?
We had these subgroups around with regions. Yeah, we had this, but I couldn't bring it because even with this, I didn't have enough.
So my problem here is that this is not telling the full picture. It's a little bit misleading. This.
Yeah, it's in an article. It's
okay.
But of course, we thought about that. It's very much depending where the data is coming from. It's all around the world, so we had to cautious about it.
And the next thing, and that was in your second topic, you mentioned that patient generalization is not easy or is not.
Yeah, exactly.
Can you please elaborate? I didn't understand why you.
Yeah, sure.
why you
So,
said that.
so all these articles have a very specific inclusion criteria. No cervical intraepithelial neoplasia before, no pregnancies, no HIV infection, no immunosuppressant. So there are certain population that they are not analyzed here. So based on this conclusion, these outcomes are examining a subset of people and not all people. So it's not generalized for example.
But is it the same subset of people, or is the exclusion-inclusion criteria system all the same for all the papers?
Yeah, very similar. Yes, very similar. Actually, because imiquimod is it has many side effects, and they used it for cervical precancer, and cervical precancer has a therapeutic model, which is conization. So they had to be careful to who to administer this drug, because of course you cannot administer this to pregnant women, but you cannot administer to HIV infected patients or immune suppressed patients because they need conization, which is the gold standard therapy. It would be unethical to give some experimental drug that we are hopeful that it will work. It will work, but only a subset of people once again. So just let me show you that 60% of patients responded to imiquimod. So it's
how funny things are. You see it as a limitation. I actually see it as one of the biggest advantages, because you're reducing heterogeneity. Even if it doesn't matter what the I-squared says and whatever.
Yeah.
Okay. You're basically just looking at the imiquimod effect. So it's not a limitation, I would say. It's more a benefit. It's a strength of the whole study, or of the whole system. That you're not burdened with other things that you need to consider because it's pre-selected.
I see your points. Yeah, I see it. Okay.
So because the question is the effect of your chosen treatment, right?
Exactly. Yeah.
So answering that question, it's beneficial to have a more strict.
I see your point.
From treating a patient point of view.
Because we relatively investigated a homogeneous population.
Mm-hmm. Exactly. So it's a benefit. I would highlight it.
Okay.
Channel your inner Hegyi Péter.
Okay. There you go.
Please go back to your first forest plot.
In this topic or
the first project? Yeah, because just to my understanding, really, here, because you list the event rate and you list the total number of patients, but you only summarize event of patients, right? And then we end up, so I can only see the total number of patients and not the patients with the event summarized, not added. And when I eyeball that, yes, exactly, when I eyeball the numbers, then is it really that much that out of almost 500,000 people, there are only 7,000, but this tells me that only 7,000 had trichomonas infection, right? Yes. And I can't see the proportion of the patients who actually had the event.
Yeah, the event is even lower.
Yeah, it must be lower.
I mean, it's probably 3,000.
But why didn't you summarize that?
We had a meeting with our statistical.
Or am I not understanding something here?
We don't know the final number, because probably they were reporting
only the odds ratio
model and the odds ratio, and you don't know. You only know the odds ratio and the patient numbers. You don't know the final number. That's the reason.
trichomonas is a prevalent sexually transmitted infection that can cause chronic symptomless infection in the cervix. And then you say, based on our research, we recommend screening for HPV when trichomonas is detected. Then how can I detect it and symptomless infection of the cervix?
Yeah, that's a very good question, to be honest. So in many cases, women come to the outpatient settings for screening. They want to know if they had sexual partner and they want a screening, or they have symptoms. The literature says that symptomless and symptom trimester infection with symptoms is around 50-50. So, of course.
And are you sure that the trichomonas, because we say trichomonas is carcinogen, but
no, based on this, so these are basically cross-sectional studies. We investigated trichomonas and cervical carcinogenesis in a cross-sectional line and not in a continuous line. So we say that there is an association between trichomonas vaginalis.
But maybe there is mycoplasma or enterococcus in a chronic infection too.
Exactly, yeah, and that's very true. That could be the case. That mycoplasma, chlamydia have the same association. Actually, they have. So it is written in the literature that sexual transmitted infections are associated with cervical cancer in general. But we had one specific clinical question, and this was the best way to carry it out because these were the reachable articles to make a meta-analysis. But your point is absolutely correct. Yes.